The opioid crisis in the age of pandemic. My name is Heather Diaz and I'm an information services librarian at Forbes. We're so pleased to have such a great panel of local experts tonight. Thank you all for being here to share your knowledge and experience. I'd like to begin this event by acknowledging that I stand and the library stands on Nonotuck land. I'd also like to acknowledge our neighboring Indigenous nations, the Nipmuc and the Wampanoag to the east, the Mohegan and Pequot to the south, the Mohegan to the west, and the Abenaki to the north. I'll also add that this program is supported by funding from the Massachusetts Board of Library Directors. To those of y'all in attendance tonight, you can use the chat to post questions to the speakers as we go along. We'll do Q&A at the end, but you can put your questions in the chat at any time. Also, if you're having technical problems, you can use the chat to reach out to myself or the other Forbes staff helping me tonight. That would be Ben and Molly. And also, we're going to be recording tonight's event. So if you register, you'll get a link to the video afterwards. Living through a global pandemic, I think, has brought to the forefront both of the urgency and complexity of public health for many of us who would normally probably be pretty oblivious. Meanwhile, ongoing uprisings against anti-Black violence challenge us to grapple with the legacies and current reality of inequitable access to treatment, the stigmatization of certain bodies and behavior, and the injustice of who can expect safety and care. My hope for this evening is that we can learn from the experience and insights of our panelists who both practice and bear witness to what is truly essential work. And now I'd like to hand things over to our first speaker, Cherry Sullivan, the Opioid Program Coordinator for the Northampton Department of Health.
Thank you, Heather. And thank you everyone who came tonight to share in this space, to learn, to be supportive together as a community, and to think about your role in how we continue to save lives and bring compassion to substance use disorder and the opioid overdose crisis that we are experiencing. So tonight I'm just going to give you a very basic overview of what Hampshire Hope is, who we are, and what we've been doing, what we've been challenged by, particularly with COVID-19, as well as a quick highlight of some of the successes and the innovations that have occurred through these hard times. Because oftentimes with steep mountains, we can find light on the other side as well. And I'll be sticking around, and you're welcome to ask questions at the end of the presentation. So again, I'm Cherry Sullivan, and I coordinate Hampshire Hope, which sits in the health department in Northampton, but we serve the entire county and we partner regionally throughout Western Mass. So what it means to be a coalition coordinator is that basically I'm a convener. So I bring folks from all different places of life, professions, whatnot, in our community to think about how we can best address substance use disorder, what we know about is happening for people with opioid use disorder, and what we can do to be part of the solution here in Hampshire County. One of the other programs that we house that I'll just briefly mention in case you have heard of it and you were wondering where it came from is a program called DART. It's called the Drug Addiction Recovery Team. And it's teams of first responders, recovery coaches, harm reduction counselors, and clinicians who work together to provide support to people after they've overdosed, if they've had trouble with the law because of their substance use disorder, if family and friends who struggle as well along with their loved ones with substance use disorder, and we also offer bereavement support. So that's a free service that we offer through Hampshire Hope, and you can find out more, or you can get support for yourself or someone you love by going to hampshirehope.org/DART, D-A-R-T. So thinking about where we're at now with the work that we do. So traditionally we get together and we meet in room and we talk about what's happening in our community, and we look at data and we hear the voices of people who are impacted by this work, and we think, what are we going to do about this? And quite quickly when COVID hit, it was apparent very quickly that there was going to have detrimental effects on people with substance use disorder and their family members for a lot of reasons. So in fact, what we're seeing now in the data, national data, is that opioid overdose rates are rising, are spiking with COVID. Though I have to say the jury's still out a little bit here locally. We're still analyzing our data, and we haven't seen the huge rises that nationally has been seen so far, but don't quote me on that quite yet because we're still looking at the data. But we also know that a reason for that might be because we're really set up to get Narcan out into the community through our organization, as well as our partner organizations that you're going to hear about tonight, such as Tapestry and the hospitals and behavioral health. Narcan is a drug that you can get. Basically, it's not essentially over the counter, but you don't need a prescription for it. You can go into a pharmacy and ask the pharmacist for Narcan without a prescription, and it will reverse an opioid overdose. So we've worked really hard over the last several years to get that out into the community, and we're wondering if one of the reasons we haven't seen the extreme spike that they've seen nationally is because of that good work in our community. And again, Jill is on the line and Deb is here as well, and they'll be sharing more about that. We also know that there's been fears about calling 911. So though the national data looks at opioid overdose deaths as well as 911 calls, when COVID hit, people became more fearful to call 911 because they were scared to go to the hospital. So again, the information that we have about overdoses is a little bit limited based on that type of data. So when COVID first happened and we started hearing the voices of people who use drugs, their family members, as well as community members who work with people who use drugs, there were a few key things that struck us right away. And these maintain today. Social isolation, we know was going to be a problem, was going to be devastating for people. Loss of employment. Difficulty accessing services because at first those services didn't quite exist, or the transportation to get there didn't exist, or the fear of one's health or their loved one's health in terms of leaving the home. Fear of seeking medical attention. We had a lot of early releases for incarceration, which in itself is a little scary in terms of overdose risk, because folks who are leaving jail are at extremely high risk for overdose. And Liz, when she talks tonight, she'll share a little bit more about the work at the jail to help reduce those rates. And the reality of it is, with all of these issues that are happening during COVID, addiction has a strong pull. And I think it's important that we remember that. It's not that people don't want to make safe choices for themselves, that they don't want to make healthy choices for themselves, but the pull of addiction is really strong. And so at a time when we are asked to take new precautions that for some people are already challenging and some people they're easy, when you have extra challenges like having a substance use disorder, it can be even harder to follow those guidelines for a lot of reasons. And I think it's important that we think about that as we bring empathy towards this issue, in which it's not people not wanting to take care of themselves. It's not people wanting necessarily to have a bad outcome or an overdose, is that it's really hard sometimes to make a choice for yourself that can be the healthiest choice when you're really struggling with addiction. So it's our role as community members to bring the healthier choice to people, to make it easier to make the healthier choice. And that's what a lot of our folks will talk about tonight. And then the last thing I'll say about some of the things we were concerned around with COVID, and we saw this, was the loss of connection. And when I think about connection, I think about a connection to a space, to people, to routine, to other humans, to love and support. And this is where I really want to give a shout out to Heather and the library staff, because they know, and many of us know prior to COVID, places like libraries, coffee shops, they're really lifelines for people in our community. And I know that might seem odd to think about, but when you really dive in deeper, they are that safe space where people can go to. They are the place of routine. They are the place where they are welcomed for who they are, no matter what. And that lifeline got lost with COVID. It got shut down. And so, initially we were having discussions, Heather and I were having these discussions about how does the library still maintain supporting people during this really difficult time? So one piece of COVID for me that was disturbing and deeply sad is that when a major pandemic hits, or even if it's a natural crisis, any sort of crisis that hits local communities or nations, it can really trigger trauma. And what we heard early on with people who were using drugs was sort of this really, not everyone, but some people, the sense of fatalism, right? So it brought triggers back of the AIDS crisis around all the stigma that people who use drugs experienced. And this sort of like, well, I'm going to get COVID no matter what, so why does it matter? And as a community, we were called to respond to that because everyone does matter. And so we were called to figure out, well, how do we continue to support people? How do we continue to do this as a joint effort, even with all of these restrictions that we have? So we really had to rise to the occasion as a community. And I'm going to share a little bit about how we did that. There's one more layer that I do want to add to this because it has made national news, and it is really important as a community that we think about this, is that throughout COVID, the national rates of suicide have also gone up. And there are intersections and there are many direct links between substance use disorder and suicide. And we really, as a community, have to start to look more deeply at these issues and think very carefully about how we are going to help and support people, because this is a real issue. And I'm guessing that many of you who are here tonight have been impacted by one or the other or both. And as a community, we need to think about, what are we going to do with this issue? How are we going to do better? In fact, the director for the Center for Disease Control, Robert Redfield, he had said in an interview, I love this quote, so we're seeing, sadly, far greater suicide rates now than we are deaths from COVID. We're seeing far greater deaths from drug overdose that are above excess that we had as background than we are seeing from deaths from COVID. So this is why I keep coming back to the overall social being and social wellness of individuals. And I love that last piece. This is why I keep coming back for the overall social being of individuals, right? This is about loving our community, finding the good in people, bringing compassion, and making sure that we create the healthiest community that we can create. And now more than ever, that's apparent. Now more than ever, we have to look at a whole system approach on how we address opioid overdose and, of course, suicide as well. We have to have a whole system approach of how we're going to address COVID, because these intersecting issues can't be just picked at here or there. It's not one person's responsibility. It's not one agency's responsibility. It's not one hospital system's responsibility. This really is the responsibility of our whole system. So that's sort of the spirit that I want you to come to tonight as we listen to the rest of the speakers who are going to share about the great work that they've been doing in our community to bring a whole systems response. Each of our speakers tonight are an amazing, important piece of the puzzle now, before COVID, and as we move forward. Because like I said earlier, even though we've had these intense challenges with COVID, it has actually opened up doors for opportunities and innovation that we wished we had had and didn't necessarily have that extra push to get there as a community. So for example, telehealth services from providers, telehealth recovery coaching, telehealth harm reduction, telehealth prescriptions of medication-assisted treatment or recovery. It was a little sticky to figure out how to do it. But in some ways, we reached people who would have never been reached before, who couldn't walk in a door for many different reasons. And so it was really amazing to see new opportunities to be able to engage people where they're at and get them the services that they need. Many of you probably heard about the emergency shelter that had opened in Northampton at the high school, and that truly was a joint effort between many different agencies and the municipality and the health department and Tapestry and the Northampton Recovery Center, who was providing telehealth, and Tapestry, who was bringing in their mobile unit for syringe access and providing Narcan and providing connection and providing some sense of routine for people, which was really important. The last thing that I want to say is, though this panel tonight was about COVID, we're all aware that COVID has really highlighted a lot of racial disparities in our community, which have continued to fuel the fight for racial justice in our community. And that intersects with substance use disorder, because people who were already feeling marginalized and stigmatized and experienced the health disparities associated with who could get the support they needed around substance use disorder are feeling that even more during COVID. And there's a lot of complications around how we as a community continue to do right by our community, but also recognize that there's a lot happening and there's a lot to unpack around social justice and substance use disorder and racial equality. And that's the work that we're going to be challenged with as we move forward together as a community, and as Hampshire Hope moves forward in thinking about how do we best serve the people who need us in our community. So before we move on to our other speakers, I just wanted to be able to show one example of something that we were able to do as a community to address the needs of people who use drugs, and specifically around COVID. So Heather's gonna show a video to you, and this video is really neat. It's something that came together from folks. It was a collaboration between Hampshire Hope, our colleagues at Tapestry, an amazing nurse advocate in the community named Kim Dion, a filmmaker who donated his time. And we were able to create this video that we've been trying to get out on social media. If you want the link, we can put it in the chat and you can link to it anywhere you would like to link to it. And associated with this is a very small brochure that's almost ready to be printed. We're still kind of tweaking it a little bit. Paradise is helping us with that. That can go out. And if you're interested in the paper copies, you can message me and I'll get those to you. And it also has a provider tip sheet that goes along with it. So what we wanted to do was make sure that providers, people who are working, whether it's in the hospitals, it's behavioral health, it's nursing, it's emergency departments, people who are working with folks who are using drugs, know those messages that we can be giving to people during COVID, the small, tiny things that really can make a difference in not only saving lives, but helping people be healthier, right? Preventing other health conditions such as hepatitis, endocarditis, and other kind of issues that can go along with drug use that we really want to try and prevent. So we'll show this video and then we will move on to our next speaker, but I'll be around here for questions. And you can also privately chat a question if you don't want to ask it while it's being recorded.
Okay. Hopefully my screen sharing is going to work.
COVID-19, best practices for people who use drugs. Wash your hands for at least 20 seconds with soap and water every time you come in contact with others, after handling money, and when you get your drugs. Use hand sanitizer if soap and water is not available. Avoid touching your eyes, nose, or mouth. If you have symptoms of the virus, such as fever, dry cough, or shortness of breath, do not go to the syringe access site. Call or text Tapestry, and they will deliver the supplies to you. Stay at least 6 feet away from others. People with diabetes, asthma, and hypertension are high risk. If you must sleep in close contact with others, avoid face-to-face sleeping. Always cough or sneeze into a tissue or your elbow. Throw the tissue away and make sure to wash your hands. Wipe down drug packages with alcohol-based cleansers as soon as you get them. Do not store drugs in your mouth, vagina, or rectum. If you have to, be sure to clean packages thoroughly before using with alcohol-based cleansers. Do not share cigarettes, joints, pipes, bongs, vapes, e-cigarettes, or any injecting equipment. If snorting, do not use money or used paper. Use a new straw. And if using with others, use color-coded straws. Prepare your drugs yourself, and don't allow anyone else to touch your equipment or drugs. If you cannot do so, stay with the person who is, and make sure they are washing their hands. Make sure you wash your hands and surface to prepare drugs thoroughly before using. If snorting, crush drugs as fine as possible to avoid damage to the nose. Use a clean item to crush the drug, not credit cards or licenses. If your injecting equipment is no longer safe, snort, swallow, smoke, or insert the drug into the rectum, also known as booty bumping. In case your dealer gets sick, plan for opioid withdrawal by stocking up on over-the-counter medications such as ibuprofen, Pepto-Bismol, and Imodium. Try to have protein-based drinks and electrolyte replacements such as Pedialyte and Ensure available. Make sure to have a backup drug supplier. Don't be afraid to go to the hospital for treatment. Alcohol withdrawal can be dangerous and even deadly. If you are dependent on alcohol, try to keep a steady flow of smaller amounts of alcohol to avoid withdrawals. Stock up on alcohol, but avoid binge drinking. If possible, stock up on drugs and drug-using equipment to last several weeks. Avoid binging. Plan and prepare for overdose. Make sure you have enough naloxone. Lower your risk by going low and slow. Stagger use when using with others. Do not use alone, but if you have to, make a safety plan and be sure you call or text someone so they know and can get help if needed. Store a breathing mask in case rescue breaths are needed. COVID-19 makes overdose prevention a little harder, but it is still possible. You can obtain supplies from your local syringe access program that will help to keep you safe. If you are on medication-assisted treatment, ask your provider about take-homes. Buprenorphine can now be started using telehealth. Ask a counselor at Tapestry or your healthcare provider for more information. If you are in recovery, use online meetings and groups for support. Be sure to check out these resources to help you through these challenging times. Together, we can help to keep everyone safe from COVID-19.
Okay, thank you, Cherry. And thank you all for bearing with me as I learn again how to screen share for the millionth time. I just want to remind folks that you can put your questions in the chat as they come up for you, and we'll get to them at the end. Our next speaker is Jill Shanahan, the Harm Reduction Training Coordinator for Tapestry Health.
Good evening, everybody. Thank you for coming to this event. I'm really happy to be part of it. I want to start off by giving a shout out to the video that we just saw, because as somebody who's worked in harm reduction for about 13 years, I've never seen such a public announcement that is so direct and helpful to folks that are using drugs and the people that are around them. So it's really refreshing to see material out there for the general public that is so explicit in talking about sex practices and drug use and ways that people can be safer. So much appreciative to that video. Share widely, please. My name is Jill Shanahan. I am the training coordinator for Tapestry, harm reduction programs. Tapestry is a pretty large agency. We have women, infant, children programs, sexual and reproductive health programs, as well as the harm reduction programs that I work for throughout Western Mass, all 4 counties actually. So as far as the syringe access programs, those are the same as the harm reduction programs. So you might hear me say that interchangeably. We operate 6 syringe access programs throughout Western Mass. We have one up in North Adams, Northern Berkshire County, Greenfield, Northampton, which has been around since 1995, Holyoke, Springfield, and then most recently we have a mobile health unit for Chicopee. So we have really been able to expand quite a lot actually in the 7 years that I've been here. So today what I'm going to talk to you about is how Tapestry has been able to adapt and rise to the occasion during the era of COVID, working with folks that use drugs and are experiencing homelessness. But before I even get into that, I want to have a larger scale conversation about how we're all practicing harm reduction on a global level right now. So as I move through this, I want people to try and have an open mind when we're talking about drug use and I'm talking about sexual practices or sex work. I want this to be a safe space for everybody. So in terms of your questions, please feel free at the end to ask questions in a respectful way. So one thing I've been thinking about a lot since COVID hit, and probably because I've always had this lens of harm reduction in the context of drug use and sex, is how people navigate risk. So right now, harm reduction can look like a lot of different things. It can look like a specific diet for somebody that has diabetes or some kind of food allergy. It can talk about, reducing smoking cigarettes, alcohol reduction, managed drug use. Sunscreen is also a form of harm reduction that a lot of people use. Drug policy and decriminalization of drugs on a larger scale is also considered harm reduction. So harm reduction isn't always just focused on drug use. So I want people to think about how we use harm reduction in our daily life, especially now during COVID. I don't think there's ever been a time in my lifetime and most people's lifetime where we have had to practice harm reduction on such a large scale. So if we think about harm reduction in the context of COVID, we're thinking about wearing masks as a part of harm reduction to reduce our spread to others and also acquisition from others. Washing hands is also a form of harm reduction right now for folks. Social distancing is definitely a form of harm reduction. And then if you think about how people are practicing this, how you individually are practicing this, how your pod or your family household are practicing this, and then also the extensions of your pod. So how are your colleagues practicing this? How are your friends practicing this? And that probably looks pretty different. I know that in my circle or in my world, whether that's through colleagues or that's friends or that's family, everybody has their own comfortability level, which has a lot of factors that play into that. So as we think about COVID or we think about harm reduction, whether that's applied to COVID or that's applied to drug use or that's applied to sex practices, we really want to think about what factors in our life change our risk profile. And sometimes that's not always what aligns with what other people want us to do or even our close people. So if you think about harm reduction on a global level and those factors such as like businesses opening up, I know a lot of people, for instance, who are comfortable going out to dinner now that businesses have opened up. And I know a lot of people who will not add that into their risk profile because maybe they deem something else in their life a little bit more high risk or a little bit more important. So maybe somebody is finally able to go back to see a doctor now or acupuncture or something like that. But they limit their social exposures, where other people can't limit their social exposure because of their living situation or because of the desire for humans to have connection with people. And then if you add the whole context of drug use to this, it gets tricky, just as Cherry was mentioning before. There's a lot of reasons why some of our folks that we work with at Tapestry, syringe access programs, are unable to practice social distancing. They might not have access to hand washing stations if they are residentially challenged or homeless. They might not have access to masks. So it's really easy for some people when we're all very heightened right now in the world to judge people on why they aren't doing what you think that they should be doing. But we need to have kind of like a more understanding on what goes behind some of these factors as to the choices that folks make. So I just want people to think a little bit about how we navigate that risk for ourselves and how do we compare that to people and what changes. And is that risk profile going to change a month down the line? Is that going to change 6 months down the line? And I think if we can think about it in this context, we can be a little bit easier with ourselves in terms of how we're navigating this, but we can also be easier with other people. I know that I get a little bit frustrated, if we're in the grocery store and somebody just goes by me really quick or they're not following the lines or something like that. But I always try to have in my mind what are the factors that drive people's behavior. And I think that helps a lot me understand, again, why people do what they do and how that can affect other people. So some of these factors that influence changing our risk profiles, whether that's drug use or whether that's COVID, has to do with isolation, has to do with our friends, has to do with necessity, as I spoke about a little bit before. So not only in the context of drug use, but I think a lot about sex and dating right now. So if you think about how online dating or app dating or all of that was going before COVID, COVID hit, things slowed down for people a little bit maybe overall, and then now people are feeling maybe a little bit more confident, whether they should or not, and they're having these, they're trying to figure out how do you navigate that. So if people are going out on dates, what does that mean for the people that they live with, you know, in terms of risk? And I think that that is kind of like a really perfect example in terms of people's behavior and basically what people are willing to kind of negotiate with themselves and people around them. So in terms of dating or in terms of sex, as the video said, some of the things that we would, you know, recommend people to do in terms of harm reduction is to reduce the amount of people that you are seeing or that you are having sex with. And if you can't do that for whatever reason, because maybe sex work is your form of employment, there are ways to navigate that risk in terms of the actual sexual act and how you're doing that. One of the tips that we would give people is to have sex from behind so that you're physically not facing each other and you're not breathing on each other. So these are just some of the ways that the folks that we work with have also had to adapt, whether that's sex work or just with multiple partners. And then also definitely, again, in terms of drug use. And I'm not going to get too much into that because I think the video that Cherry just showed was a really great example of what we are trying to educate folks on. You know, and in terms of Tapestry and serving the community during this time of COVID, I couldn't be more proud of the folks on my team and the harm reductionists at all of the sites and everybody that's involved in this work, because we're all dealing with the same fear and we're all dealing with the same heaviness that's going on right now in the world. And these people are still showing up for people that a lot of others won't show up for or can't show up for. So in terms of how our programs have adapted to meet the challenges of COVID is we never stopped operating. And that speaks volumes, I think, of the people that we hire and the people that, you know, contribute to our programs, whether that's people that volunteer with us or collaborating agencies that work with us. And some of those things have had to look different in terms of social distancing. So we've never shut down our programs during this entire time, but we have had to adapt. And some of those adaptations, as Cherry mentioned before, have been really amazing initiatives that we've wanted to pursue before, but maybe either didn't have the capacity or we didn't have that push. And some of those have to do with mobile outreach. So we've always done outreach, but we were able to get a few more mobile vans and literally do delivery services, which is something that we were unable to do before. So at the syringe access programs, we do provide sterile syringes and other works for folks that are using drugs. And all of those supplies basically help reduce the spread of infectious diseases and keep folks as safe as possible. So to reduce people's exposure, they're able to give us a call and we're able to deliver these services to them. And that includes naloxone or Narcan. And any of the training that goes with those supplies that we give out as well. So that was one of the biggest things that we were able to do, is to expand those services at all of our sites. So that has been a really big help, I think, for folks that are using drugs to not have to leave their house if they don't want to, and then we're able to provide that. We also have on the horizon medical vans that are going to be able to offer even more medical services that Tapestry isn't not able to offer currently at our brick and mortar sites. So that's something exciting on the horizon. And then also, you know, in terms of the challenges that we have faced with COVID, one of the things that harm reduction really embodies is connections and relationship building with people. And that has been one of the bigger challenges during the era of COVID for our staff. and connecting with folks out on the street during outreach or even in our sites, because we've had to literally set up our sites in a way to keep our staff safe as well as to keep our participants safe. And what that means is limiting certain amounts of interaction inside our buildings. And that I know has been very difficult for staff and for participants, because we're so used to spending a certain amount of time with people, you know, doing certain educational trainings or having, you know, really deep personal conversations about drug use or just about life. So I know that that has been one of the hardest challenges for staff and our people that we serve to adapt to, because we want to make sure that everybody is as safe as possible during this process as we continue to figure out how do we, you know, continue to navigate public health, harm reduction, drug use during COVID. And I think what's interesting, like I was saying in the beginning about harm reduction and this pandemic right now, is that people who use drugs have always had to navigate risk. So as Cherry mentioned, you know, this has brought up a lot of trauma for people that have lived through the AIDS epidemic. And that is a risk that a lot of people that use drugs have had to navigate before in the past. And then also, you know, an increase in hepatitis C, and then also with this, you know, the opiate crisis that we find ourselves in now. So people that use drugs are pretty resilient and pretty smart. And they've always been able to figure out how to navigate these risks. And, you know, what Tapestry does is come in and provide the tools to help them navigate those risks, whether that's through overdose prevention, that's through access to syringes and other works, as well as referral-based part of our program where we're able to help people get into detox, or we are able to help people get onto medicated assisted treatment, such as Suboxone or methadone. So during this time of COVID, for the people that are using drugs, they've, again, always kind of had to navigate these types of risks. So it's just like adding another one onto it. So they already know how to keep themselves safe as much as possible, given the tools, but then we have this whole other risk as well. So we really are trying hard to still serve the people that are visiting our programs, and then also reach out to people that might not have access to our programs. So that's another big success with the mobile outreach that we've been able to do, is extend our services to people that might not have ever even come into our program, but now they're aware that we are able to do mobile services. So we're able to have a far further reaching net, basically. I think at this point, you know, again, what I want to highlight is the resiliency that I see within the harm reduction community, whether it's staff at Tapestry or other colleagues across the state that I'm aware of. I've never seen such a group of people step up to the plate constantly and consistently. And I'm grateful to be part of this community, because it is a community that really rallies together, that knows how to take care of people. And I think that as a community of harm reductionists or people that work in this field in general, that's always something that we're going to be good at, and not even good at, but that we're going to be great at, and continue to help people out as much as possible. And I think that's where I'm going to end for tonight.
Thank you, Jill. You touched on many things that I want to ask questions about later, so I'm so happy to have heard you speak tonight. Now we'll hear from Deb Flynn Gonzalez, Program Director of the Hope for Holyoke Peer Recovery Center.
Hi, everybody. Thank you for having me tonight. What a great way to spend the evening. I just got back from vacation and I thought I'd, you know, ease into it, and I'm boom right there, right? But it makes me think of something, and as Jill was speaking, I couldn't help but remember when COVID, when we first started, you know, getting word of the pandemic, and, you know, we were kind of preparing for the inevitable closings and things like that. And, you know, everybody was closing down and nothing was open, and it seemed like everybody was kind of running to their own safety places and everything. And we were still there. And actually we were there with Tapestry and others. And one of my colleagues and friends said, you know what, Debbie, that's because, you know, we're people in recovery. We don't run from the fire, we run towards it. And it really made me think, you know, as a woman in long-term recovery myself, how true that's been in my life. And in many ways, you know, thank God for that, because there were a lot of folks still doing the work when we needed to do that. So I'm the director of a peer recovery sports center. For people who don't know what that is, there's I believe, I want to say 28 that are funded by the state, by the Bureau of Substance Addiction Services through DPH in Massachusetts. And then there's a slew of others that are popping up. And our hope has kind of always been that there will be a, you know, recovery support center in every town, like a pharmacy or a senior center or whatever, because they're so valuable. And the value of peer support, it really takes a whole new level of care. And when we looked at the beginning of COVID, how do we do that when our primary, you know, all we do is social connection, and how are we going to maneuver that system? So I do have some slides I'm going to try to share just to keep myself focused, and also to be able to show off some pretty pictures. Let's see, let me go to show from the beginning. Okay. So, and this is what I'm kind of call this, like, during COVID-19, from epidemic to pandemic and back. And it's kind of, that's where we've been, you know. But this is, I like to show these because it gives you a visual of what a peer recovery support center does and is. And this is the crux of it. We are a group of people. We you know, it's people coming together in all stages of recovery. So if you're not familiar with recovery support centers, we say you're in recovery when you say you're in recovery, and that doesn't necessarily mean being abstinent. So we don't define it in that way. We don't define it for anyone, whatever path you're in. And basically I say, if you're coming through the door of Hope for Holyoke or a recovery support center, you very well may be still actively using, but you're, you know, the coffee's only so good. You're coming for something and you're listening to things, and there's something that you're looking for. We don't have any rules about what recovery you're in, or, you know, whether you're not using, or the only real guideline is you have to be able to participate and engage in what's going on in the center, so you can't be impaired. We don't ask why. We don't really, if you're impaired and you're falling asleep during a meeting or in front of a computer screen, it doesn't really matter the whys. It might be because you're homeless and we're up all night, or you're going through some things, or you just used. But that, it doesn't really matter to us. It matters in the sense that we want to support you, but you're welcome to be there. You may not be able to be there if you're not present physically and able to be in that moment, but you can come back. And it might even be an hour later, or it might be the next day or a couple days later. So that's kind of the crux of what we do. So this is what we looked like before COVID. These are just some kind of pictures that were taken. So this was our Hopi Awards, which we have every year. We give awards to people for their recovery, and we had a limo, and it's like people gather. That's like a red carpet event. And this was just in January, the end of January, celebrating our 5th anniversary. We go to events together. Many people will say, oh, this is the first time I've ever been to a hockey game. We experience together a lot of firsts, like people who've been using drugs actively in their lives, and all of a sudden find recovery and find a community to be with, have never done these things. And I would always hear, wow, this is the first time I've ever done this. This is amazing. That was a Thunderbirds game that we really enjoyed. We eat together. We break bread together in our kitchen. That's something very common that people do. The door's always open. You can come on in. There's a lot of laughter. There's hugging. There's dancing, all of that. And we go on trips together. This is our annual fishing trip, where we go to the Hyannis, to the Peer Recovery Center, and people fish or go to the beach. And these are the things that people in recovery are just learning to do and doing together in community that is safe. This is before COVID. Now, right after, when we had to, this is the same spaces that you were looking at earlier outside. Now we have X's outside the door where people have to stand to come in. We can't serve coffee anymore, though we're just now doing that again in a safe way. This is what our space looks like now. It's cleared out. It looks very different. That was the actual same space that people were at the Hopi Awards in the red carpet, full of people. It's really striking how different it looks. You know, we have one computer that people can use with a lot of, you know, sort of safety regulations put in place. And these are how our meetings look like now. Although now we're morphing towards hybrid meetings too, which is good. But right after COVID, that's how they were looking. So it's kind of very interesting to see the difference when you see them right together. So preparing for this unknown, we kind of knew pretty quickly. At the end of March, all of the peer recovery support centers finally had to close. And prior to that, we were still hanging in there. And like when we were the only ones like on the block, it was getting rough. Things were, you know, when McDonald's closed and the library closed and everything was closed in Holyoke, it was like us and Tapestry that were still out there pretty much. And it was really tough. And we were starting to see what was really going to be. That's a picture of me and how I looked when we finally had to close. The reason I put it there is because it was also still cold. It's important to look at that, you know. I had a hat on, you know, it wasn't nice weather. So people who were homeless were out in the elements for sure. So what we did was, like when I say we ran towards the fire, we just had to mobilize quick and say, all right, what are we going to do? We got to close. What are we going to do? And kind of gathering people. All right, give me your phone. Let me show you how to get Facebook, you know, and just sort of putting everything in place. And how can we do this? And, you know, doing quick trainings to people and, you know, just trying to put things in place to try to support people, knowing that we don't know what's going to happen in the future. So we gave people buddies. We just, you know, kind of buddied up with peer leaders and people that had some good recovery and staff and kind of, you know, developing a little list and ways that we could keep in touch with people because we knew we would lose them. You know, and then we quickly just tried to develop some resources to give people quickly, you know, and even equipment, whether it be phones or Chromebooks or whatever, helping people to get an email, helping them to install apps, those things just really quick while we were still kind of almost able to be in the building. And just preparing like for the unknown, as I said. And really a survival guide too, with just all of those things that they really might need. When we're in the event that we're unable to be contacted or they can't reach us or they can't go anywhere. We had developed some hotspots. We made sure our wireless people got our password so they could be outside of our building and accessing that. If they weren't able to go to the library or wherever there was a spot that they could gain access to. So the first thing, of course, we realized after doing this was it worked okay for some of those people that were in, you know, some recovery, our peer leaders and whatnot, but the homeless. And we've talked about this, I'm not going to get into it too much, but, you know, once everything closed, that was a big problem. It was a very big problem in Holyoke. As Cherry mentioned, they had, you know, a shelter out in Northampton that a lot of great people quickly worked to put in place, but we did not have that in Holyoke. And they had one in Springfield, but again, we're Holyoke, and it became, as those places filled up quickly, there really was no place for our people in Holyoke. And so like a group of us just kind of got together, providers, and it really was us and Tapestry and a nice coalition of folks from the Healing Communities study that we were working on this issue even prior to COVID. And we said, look, at the very least, you know, I mean, we're going for low hanging fruit. Can we get a, you know, sanitizing station, you know, and maybe a porta potty? Because literally people were going to the bathroom in the streets. I would see them at Hope for Holyoke. They would beg to come in and use it when I wasn't even supposed to be there. And it was inhumane, to say the least. And we had to really fight for that. Quite a large group of us did. And from everyone to the mayor and the city council to the health department. And it, I think, took a little long, but we finally did get that. Again, I agree. Jerry said this, I think, too, and maybe Jill as well. There was that general feeling from people, I'm going to get it anyway. So, you know, what's the difference? And we did start to hear that from our folks, and particularly individuals experiencing homelessness. So we just kind of convened and got the city officials to give us that. That's what it looked like right there. And it was outside the library. And things happened with that even. Let me tell you, it's not, I could say, I wish it was, you know, it all worked out good. It did work out good for a while, and some really good things happened. We ended up going out there, and throughout the whole pandemic, Hope for Holyoke was there, and Tapestry and some other folks came, and we were sort of this renegade group that were doing outreach under the tent that the city then gave us. And all this time, the library was closed, so nobody really cared. And then the library opened, and that's another story. And it opened for, you know, curbside, and the folks at our library were not so happy that that there were an increased amount of homeless people hanging around there. And, you know, they were there anyway, but they didn't want them to be seen, evidently. So this is a fight that we continue to fight. And we're going to keep at it, and we have been. But we do still have it. It was moved just kind of across the street. And we're still doing that outreach work. I'm going to show you kind of some of the things that happened through that. In just from April to June, and this is what we tracked. We had we had nothing really in place, but 56 people sent to detox in that time. 20 to the ED, and those were for different things. Like it might have been COVID related, some to connect to MAT, endocarditis, all sorts of things. At least 10 a week, which we estimate to be about 100 people, just need to make phone calls. They didn't have the ability to make that. And then we had a wireless phone company come join us, and they were able to give people phones right there. And they needed to contact their, worker, find out why they didn't get their Social Security check, all of those kind of things. And many were seeking treatment, and we did connect them as well. They needed masks. They couldn't get on a bus without a mask. They couldn't do anything without a mask. They didn't have masks. We gave out a lot of those, 55 the first 4 days we were at that tent. And 4 people actually had their lives saved in that brief period from April to June, personally by staff or peers at Hope for Holyoke, because they had overdosed in the porta potty, which people could and did say, well, we knew that was going to happen, and my answer to that would be, and if we weren't there, they would probably not be alive. And we gave away a lot of Narcan. And then Tapestry, when they were joining us, did as well. They did some testing later on for other communicable diseases, and just gave away a lot of personal care items, all those kind of things. So some really good things happened out of being there. We continue to be there now on a part-time basis, even though we are now open with limited capacity. But what we did find was that as soon as we started going there, the word got out fast, and then they knew, and people came and were looking for us. And sometimes you could just see they were just craving that connection. Like, oh, I thought I heard you guys were going to be here. Wow, and some people wanted to just help, like just to say, hey, can I help you? There were people in recovery, and many people came seeking treatment. So it was all in all an eye-opening experience, I will say. So that was the beginning of our focus, was really looking at that population that was without any sort of assistance and were homeless. Then we had to prepare for this virtual world, because we didn't want to also leave out our people that were in recovery. So we, as I said, kind of quickly tried to mobilize that. The peer leaders who were doing groups, most of our groups at Hope for Holyoke are done by peers. So we prepared them and got them Chromebooks and set them up, gave them a little training if we could. We happen to have the luxury of having a staff peer leader who used to work for a news studio. And so he had some experience, which was like really great, because many of us don't know anything about this or thrown into this world. So really by week 2 of our official closing, we had 48 different groups on either Facebook Live or Zoom, which was pretty awesome. So that's kind of how it looked. You could go in and find a group, and they were usually just the groups that were normally happening. Anything from, medicated assisted recovery to arts for anxiety, so it was all sorts of groups. These are groups that members propose during community meetings, and they are approved, and they provide these groups within the center. Well, now they were just doing it in a different platform. This is our Families Recover group, which we have a puppet show that a lot of we do and kind of put that out there. And we started putting that onto YouTubes and would send that to family residential programs who were showing it. And so like the puppets would be showing families, you know, how to make Play-Doh, you're stuck in the house and things like that. And how do you parent in recovery when you are, you know, also quarantined and those kind of things. So we continued to do those type things. Everything from refuge, recovery, tobacco awareness groups, all of our regular groups. We had to develop some new kind of on-group guidelines. Trying to maintain confidentiality and anonymity is really different and looks very different when you're doing things virtually. So we adapted those. And then we evaluated and really had to look at what worked best for our folks. Facebook versus Zoom, and Zoom was very challenging for a lot of people. Yet Facebook, everybody could get on. And we started to see that they were becoming much more utilized and people could then go into them. We developed what we call the video vault, which people can just go into, and then at 2 o'clock in the morning, you can watch Maintaining Wellness, a kind of relapse prevention type group. And that became very useful for folks. And people were also accessing these that had said, I always wanted to come into Hope for Holyoke and I was afraid. Or I just, I couldn't do it because I have my kids at home. And a whole new population was then accessing these resources. So those are the pluses. We have a radio show type that continues to happen called Noah's Ark. This is Kevin, who we call Noah, and it is widely seen. Like he gets, like on this particular night, there was 102 views. He gets a lot of views, like in a night, and then in the video vault. And it's just like kind of I call him like the Howard Stern of recovery, but he's cleaner than Howard Stern and much more appropriate, I will say. But he just has guests on, and people really enjoy hearing him. And at 8 o'clock at night, they like, oh, I got to go onto the Ark. It's their like touchstone. You can check him out on our Facebook page too. Any of these things, we have a virtual calendar too, so you're always welcome to look at that. He has a following of people called Arkheads. That's Kevin. So where are we now? Well, we're open. This is what we look like now. It's a whole different look. We have a very limited capacity right now. We're working up to 20 people, but 10 at a time for the space that we're like licensed for, just one of them, but we're going to be increasing that. And we really try to look at assessing people's readiness in coming back so that we can really try to get the people, if they've been used to utilizing virtual supports, then we try to encourage them to continue to do that and really try to get the folks who have not been doing that. And literally the day we were open, and even before that, when I was coming in, people were always like, are you open yet? Are you open yet? I need you. I need you. And that's what we've really been seeing. We're now doing hybrid group models, which look like this. So sometimes we'll do like a piece of a writing group with writing prompts on Facebook, and then they turn it off and continue live in a group. And those kind of things are happening. Some of our groups, like the morning motivation meeting, which is our like staple group, people were very clear, we don't want to be on a virtual group. We need this group to really be able to vent and talk. And so we have that still going on Facebook, but it's a private group. And we suggest that people make like a reservation. And then how do we move forward? Well, we're continuing to advocate. So like I said, with the library, there was a lot of stigma that went around with that, but we're working on that. And we know, and it's not a diss to the library, they really just didn't understand. They left in the beginning of COVID when things were very different, came back, and it was like a whole different world. So we're working on that with them and continuing to strongly advocate as we move towards a new season, to getting our city to respond to the needs of individuals experiencing homelessness, by at least pushing for a seasonal shelter in our community, because it's been long overdue. And now what we're finding is we're really having to deal with relapse and loss. And I said in the beginning, it's kind of like we went from the epidemic to the pandemic and now back again. And what, our focus is now kind of morphing back to, we are seeing people that had some long-term recovery relapse. And some of them we have lost, far too many of them. And so now we're looking at this and reaching back out to some of those members and people we knew. And frankly, it's been staff, it's been peers that I have worked with that have this pandemic, COVID, has taken them back out. And it's sad. And one of the things that we've really started to look at, and we've talked about it for so long, is we need a space for peer workers in this, that work in this field, to come without supervisors and people in their administration, that they can go and say, you know what, I effed up, or I'm really, you know, I'm really struggling right now, and not be afraid to lose their job, but get the support that they need, because that has kept people out there too long. And so we're really looking to put that in place like yesterday, because I've seen it, and I just don't know what else to do about it. And but I believe in peer support, and I know that peers can support each other in a way that clinical services and nothing else can. So that's kind of what we're looking at, and you know, we've learned a lot of lessons from it, and it's been hard, and the losses have been hard, but I think that we're in a place where we can now move towards like doing things we never thought we could do, and that is an amazing opportunity. So this was we lit it up purple for overdose awareness, and those were some of the people that we did lose, and we had a lovely night. But I just want to end with the end of our mission statement written by our members. Hope for Holyoke offers not only recovery, but discovery in one's hopes and dreams. It's a place where the impossible becomes possible. This center offers hope. And that's what we end every single meeting with. And I truly believe that in my heart. So thank you. That's all I have.
Thank you so much, Debbie. Our final speaker tonight is Liz Evans from UMass. She's a professor in the School of Public Health and Health Sciences.
Hi, everyone. We can do this. Thank you for staying on. I know it's getting late. I myself am like, I need to go to bed soon. So I also brought some slides that I'm planning to share. It's really, again, a way to keep myself organized with what did I want to say? So I come at this for a little bit differently. You know, I am a researcher. I've studied addiction for about 20 years, mostly in California on the West Coast. I came to Amherst about 3 years ago, where I, you know, in meeting Cherry and many others in the community, was able to get some community partnered research going. And one of those I want to share with you today. A little bit though about myself and my research. I do tend to study people over long periods of time to try to understand who achieves recovery and how do they go about doing it. And I'm especially interested in the factors that explain that recovery that are above and beyond the individual and are instead about the context that people engage with. So institutions, systems, the neighborhoods that they live in. How can those be factors that influences people's ability to recovery independent of their personal characteristics, like their sociodemographics? And a lot of the studies I've worked on have taken this long-term life course approach. So we study people and engage with them for 5 years, 10 years, 20 years, even over 30 years to understand who achieves recovery, how, and can we sort of quantify or isolate the factors that explain recovery such that we can better leverage that information for like resource allocation and other decision making. So that's a little bit of background about myself. I'm going to do the slide sharing. When I do this, you all can see it. Okay. So I was going to talk about, you know, lessons learned from that research where we studied over long periods of time. We can document, it's been empirically supported that, you know, opioid use is like a chronic disease. Some would say that it is a chronic health condition. So we see people in cycles of use, they do change their use, they achieve abstinence, they maybe return to use. I'm especially interested in how do people achieve lasting recovery. So recovery that endures over time. And how we define recovery is a big open debate. We could have another time. It's also challenging that many people with opioid use disorder, you know, they struggle to stay engaged with treatment over time. They may never go to treatment. And that's a challenge we recognize now that we need to do better at addressing. But it is the case that patterns of opioid use do change. It's not as if people keep using at a high level for the whole life. No, it fluctuates. They, you know, reduce their use. They have a low level use, maybe even no use. And so that's heartening because it's this idea that it is possible to achieve recovery, to say it in another way. And so I'm interested in how can we support that positive change and help it to endure and last. And research, a lot of research, some of it's my own, but many other researchers in the United States and elsewhere has shown that treatment with medications can be a turning point event that can help people change the course of their opioid use disorder. And so what are these medications? I think pretty much everyone on this call knows. I'm talking about medication-assisted treatment or medications for, opioid use disorder, mood, or MAT, that's how it's often called. And these are these medications: methadone, buprenorphine, naltrexone. They've been approved by the FDA. Several studies, including randomized trials, have demonstrated that they are helpful at enabling people to achieve positive health and social outcomes, especially in comparison to no medication at all or no treatment at all. So there's been this real push and recognition to how can we make it possible for more people to access this type of care. Other little sort of, facts from my research and that of others is, of people with opioid use disorder, less than 10% ever do receive those medications. And that's a major gap in care. The need treatment gap is a big one there. Many people use opioids for 10 or more years before they ever do go to treatment. And that's a long time to be using a substance, one that can create other health vulnerabilities that become, additional comorbidities that are challenging for people to address. When people do go to treatment, they still encounter treatment centers that do not offer these medications. Many more years are spent incarcerated than in treatment. And those experiences of incarceration elevate people's risk for mortality. And it's really this last point is where I focused my research since I came to Amherst, is how do we better serve populations who are involved with the criminal justice system who have opioid use disorder, who historically have been underserved and recognized to be especially vulnerable for opioid overdose, yet systems of care often historically have not really addressed their health needs. So I'm a part of this initiative that's trying to just document and create graphics like this one, just maybe more easily showing people the problem. Like, so many people are incarcerated in the United States. A significant proportion of them do have opioid use disorder. Very few of them, a small sliver of them, ever receive those medications while they're inside jail or prison. And why is that? Well, a lot of these institutions have policies that explicitly prohibit the use of those medications inside these facilities. And so that's recognized as being a major problem. If we really are serious about doing something about the opioid epidemic, we need to address the care that's being delivered inside of criminal justice settings. How can we maybe adapt or adopt healthcare that's known to be effective out in the community inside jails and prisons and other settings? And so many of you have heard of HEAL. The NIH, National Institutes of Health, invested a lot of money in the last few years under their Healing Initiative to fund initiatives to address the opioid epidemic. And this is sort of a little graphic of their portfolio. They break down how the federal government uses its resources to address pain management or to improve treatment outcomes. And the work that I do is in this treatment outcomes box, especially in this optimizing effective treatments. But it's important to recognize, like, there are a lot of other endeavors going on at the same time all around trying to address the opioid epidemic. Several of you have talked about the Healing Community Study. That's a huge effort that's happening now in Massachusetts. Massachusetts is been very successful in securing federal dollars to invest in addressing the opioid epidemic and to research the impacts of those interventions. And Healing Communities is a very well-known one. Another one that's a little more recent on the scene is called JCOIN, the Justice Community Opioid Innovation Network. And that's the group that I am most engaged with. And so what's JCOIN? They are very focused on, how do we address opioid use disorder among people who've been in the criminal justice setting, either jail or prison, probation, parole, courts. It's a very broad definition of what do we mean by a criminally involved person or criminal justice involved person. And the overall goal is to create new evidence about what works for this population and how do we go about implementing that effectively, to be a resource for communities elsewhere if they're thinking of tackling this problem among a criminal justice involved population, what is working well elsewhere that they could maybe utilize to create this coalition of researchers and practitioners who are working together in these different settings, building capacity to do research in justice settings, and then this translation of science into practice. So it's exciting to be a part of this network. It is a large network. There are 11 research hubs. Massachusetts is one of them. And together they're doing work in 21 states and also Puerto Rico, impacting 87 communities, and they're targeting more than 40,000 justice-involved individuals with opioid use disorder. So it is meant to make a nationwide impact, especially on with this population. And these are the different hubs that are funded in just very brief snapshot, like where are these hubs? There's 11 of them. Massachusetts is one of them. You can read more. There's a little link down here. You can click into this and read all about each of them. I'm going to talk about the Massachusetts hub because that's the one that I'm leading with Dr. Peter Friedman from Bay State Health. And we're part of the thematic area of, how do policies around criminal justice involved populations, how do those policies impact healthcare that ultimately hopefully leads to better health outcomes. And I'm going to skip to here. We lead the Massachusetts J-Coin Research Hub, or Mass J-Coin. And it sort of was an irresistible opportunity to be funded to lead this hub when we learned how in Massachusetts a new law was passed called Chapter 208 that was implemented starting last fall, in which originally 5 jails in Massachusetts and ultimately 7 stepped forward to be the first to implement medications to treat opioid use disorder inside the jails. So it's these 7 counties that I've listed here in red: Franklin, Hampshire, and Hamden, Essex, Middlesex, Suffolk, and Norfolk. And so they're, really taking on the challenge and on the forefront of taking what's known to work in the community and trying to implement it inside jails. So we thought this would be a great opportunity to study what does it take to deliver a program like that? What are the practices that are required to stand up a program like that inside the jails? And also, what are the outcomes associated with a program like that? And how much does it cost to deliver a program like that? So those are our 3 main research aims. I listed them here a little bit more in detail. What's pretty cool is we'll be able to study everyone who moves into the jail and out of the jail who has an opioid use disorder and understand what type of care did they receive while they were in those jails. And then as they were exiting, what type of care were they linked to upon exit from jail in the community? How well was that linkage done? What proportion of people actually continued care in the community and remained engaged in some way? And then what are the outcomes associated with those different constellations of care? So the ultimate question, what works best for which type of person? That's the type of question we're hoping to answer with our research. And then yes, to document promising practices such that if there are jails or maybe prisons elsewhere who want to implement other similar programs, we can give them a nice playbook, perhaps, that they can work from. And then, provide estimates of how much does it cost for a program like this. This is a huge project. It involves a lot of research partners. The 7 houses of correction and the sheriffs who lead them and their staff have been amazing, very collaborative and willing to allow us, the researchers who come from the outside, to embed our research staff there on site such that we can collect the data that we need. We're also working with the Massachusetts Department of Public Health very closely, and about 21 community treatment sites who are the ones that people are primarily being referred to as they exit jail and are being referred to treatment in the community. So it's been really great to work with such a cool and amazing team of community partners. And all of this was really exciting. The jails were standing up this program starting in last September, really getting the groove going. And then, in March, COVID-19 happened, which had major impacts on the jails. So like what you all have been talking about in your community settings, the jails also needed to observe COVID mitigation practices, which meant immediately non-essential staff could not come into the jail anymore. And that really put restrictions on the psychosocial treatment that they could offer for addiction and mental health inside of the jail, in the short term at least. Sort of encouragingly, they determined, provision of those medications is considered an essential service. So they did continue to deliver those medications inside the jails. And that we took that as that's a good sign that they found a way to be able to keep doing at least that part of the program. There was this mandated rapid release of nonviolent pretrial individuals, and the jails create a lot of work to figure out who could be released and how. And often people were released without the jail being able to really connect them to care in the community in the way that they would like. It was just happening too rapidly for them to do much except just release them. Now they're still trying to figure out how do we deliver physically distanced medication and other services inside the jails. And given that there's been a reduction in the numbers of people arrested or coming to the jail, how do we intervene with this population who's maybe in the community but is no longer appearing inside of the jails? So it's sort of a promising practices are now being implemented. There is a much greater use of telehealth inside the jails and also in some of the courts. And that's been amazing to see. And some other innovations are being implemented that we're now talking over, how would you sustain this? What's worthwhile to keep doing? The jails have also implemented these systems to track COVID-19 itself. And so that's, been a huge education about public health, and a lot of the go-to practices that public health does has now been assumed by the jails, and they are doing these practices. And so that's been an interesting shift in their role and responsibility in many ways. So general just thoughts for discussion, and this is my last slide, is challenges from what we're hearing in Massachusetts, but also across the country, is things we already know, the risk for overdose from fentanyl or other synthetic opioids. But an emerging threat is the use of stimulants with opioids and people overdosing on the co-use of those two substances, especially in the West Coast, but I'd be curious to hear if here on the East, we're also seeing it as well. What others have talked about, isolation, the lack of peer support, the need for how do you get social support in the COVID times, the comorbid health conditions like stress, suicidality, physical health conditions that can create a vulnerability for COVID. How do we address those? And the video that Cherry shared is the type of thing that's needed for our population. Especially given that people may be afraid still to go to emergency departments or other places to get help. How can we empower them to hopefully be safe? And there are these opportunities, doesn't sound like the right word because COVID is such a horrible situation, but this chance to do things like revisit addiction treatment policies. So the ability to enroll people in buprenorphine treatment with really low barriers to that is a major shift in how that type of treatment has been provided in the past. And this idea to raise greater awareness of how public health is connected to the criminal justice system, which is connected to health equity, which is all of these things. Again, returning to what Sherry talked about at the beginning, it requires systemic and very big attention from many, many players. And that's really it. We are continuing our JCOIN work. We hope to have findings in the upcoming year, some early findings. So hopefully I can come back to the group and share some of that. And that's it. Thank you.
Thank you, Liz. I'm cognizant of the hour, but also I had a question that I wanted to pose to all of our panelists. A couple of you touched on this already, but this was on my mind, before we started tonight, that, over the spring and summer, I think, myself personally, many people have really struggled to digest and apply public health information, particularly around managing risk. And yet, both professionally, socially, in your larger networks, you're situated in this space of incredible collective wisdom on this topic. And so I'm curious, what principles of public health do you think have been most misunderstood? Or put another way, what from your background and in your experience have you found most helpful in dealing with this new layer of crisis? It's kind of a big one.
Yes, big questions.
But you can think of one little thing like, oh, I was reading some harm reduction literature early today to, prepare, think of good questions for y'all. And this is like a throwaway slogan, but one thing I was reading was just saying, oh, better is better, which is it's very basic, but it's very easy to understand. It's very easy to apply, and it's very humane.
That was where I was going to go with that. I mean, my first initial reaction was like, just one small act of kindness, and it might be nothing, like, but stopping, on the corner and giving somebody a sandwich and talking to them, and during COVID-19 when no one is, like, I mean, I can get myself in a lot of trouble and often do, but, letting someone in to, use the bathroom and giving them a cup of coffee is something I'm going to do if someone really needs that, or giving them a blanket and, or a tent or whatever, but those, you're right, better is better. And one of the things that I often say is you have to be alive to even start thinking about recovery, so let's just start there. And in order to do that, I think people just want to feel like somebody cares.
One theme that I think has really resonated with me with COVID that relates to the topic of opioid use, as well as pretty much every public health issue, is that the concept that shame does not work. Mm-hmm. And that shame actually drives people away from the healthy behavior that we're looking for them to engage in. So, and that, that really rings true with COVID around people feeling, should I approach someone because they're not wearing a mask? And then the shame and the stigma that we put on people, whether it's around their eating or it's around their drug use, or it's around what gas guzzling vehicle they drive, like there's lots of public health issues that we put shame on people. And when we put shame on people, it drives them further and further and further away from a healthy choice, because we need to build people up, not break people down for them to live healthfully. So that's the theme that keeps coming through for me. And I have to put myself in check a lot when I see something or I see someone who I believe is not making the right COVID choice. I have to put myself in check around that.
Yeah, and really just building on that is the idea, like, your life has value. So we're talking with you about this because we care about your health and safety, not because we want to punish you or make you feel bad in some way, but it's all about your health and the community's health. But how to communicate in a way that's what's communicated and not misinterpreted in a different way is very challenging.
I think one of the things that we've experienced at Tapestry is during this COVID phase is really getting basic, correct information out to people that use drugs and people that use our program, because there's a lot of people that don't watch the news. There's a lot of people that don't, read articles on the internet. So I think we were able to disseminate factual information to people, like literally quick spreadsheets, not spreadsheets, but lists really quick for people to navigate their risk. And I think coming from an agency that these folks already trust and, are able to talk about really vulnerable things with staff there, I think we already had that trusting relationship. So when we were able to kind of say, like, this is what you should be doing, or this is how you should be doing it. If you can't do this, this is an alternative for that. I think really meant a lot to people because they already trust the information that we provide. So if they don't have access to this information, they have access through us.
So we have a question in the chat about DART, and I'm going to try to summarize it, but Emily, who's asking the question, please feel free to add more to the chat if I'm not capturing it. So this is a question about the involvement of police officers in DART. Does this impact the criminalization of people who use DART, or how does it work to have police officers taking on these roles in this way? Maybe this is a question for you, Cherry, but if others want to chime in.
That's a great question, and I'll let Jill chime in if she doesn't feel like I've answered this question thoroughly. So this is a really great question, and I'm glad that you asked that, because Emily, in the beginning I said that we really have to look at racial justice when we think about substance use disorder. So when I described DART, I mentioned that their first responders and police officers are included in that. And our DART model has been evolving with time, and it continues to evolve. And through that time, the program, as well as the officers who are involved in DART, have come to realize more and more what their role should be and what their role shouldn't be. So that's taken a little bit of time to sort out. But here's what I can say, is that DART officers are officers who are specially trained and highly committed to policing differently when it comes to substance use disorder. And so they're officers who recognize everything that Jill has said, everything that the video said is more important than criminalization. They are officers who believe in handing out Narcan on the street, who believe in safety planning with people, and ensuring that they are using their drugs more safely. Now, however, they do work in a larger system of criminalization of drugs. Right now, heroin and illicit opioid use is illegal. And so this is the push and pull that our DART officers experience, where they want to change the system. They would like to see things done differently, and yet they work in a particular system. So this probably is an hour-long answer, and I'm hoping I can summarize it really succinctly. What I can say is that through time, we have seen departments change the way that they approach substance use disorder, from criminalization to hoping that people can get support and directing people towards that support. So whether that's making a call to a recovery coach and saying to someone, hey, I have a recovery coach on the line, are you interested? Or, hey, do you know about Tapestry? Or, hey, are you interested in any sort of treatment resources? I could get you to detox right now if you'd like. So I think that their thinking and their culture is evolving more and more and more around the idea of, this isn't an issue that should be criminalized. This is an issue in which we need to be providing compassion and support. And that culture shift is going to take time, but the officers who have committed to that training come in with that mission and that heart. It's not perfect, and we are constantly trying to figure out how to do better. And like I said in the beginning, we're actually going through an evolution to make sure that we are using officers in the most appropriate way as we've learned what works about the program and what doesn't work about the program when it comes to officers. So I'm not sure if that specifically is answering your question, Emily, and you're welcome to chime in a little bit more if you'd like. Jill, I don't know if you have anything you want to add to that.
No, I think that was pretty on point.
Okay, there's one more question in the chat about wondering about the failures of pain medicine or pain management in our healthcare system, and how does that reality tie into what we are hearing about tonight?
A big question. Oh, good, Jill, you tackle
No, Liz, go right ahead.
Like, I guess this idea we all recognize that inappropriate pain management has contributed to the opioid epidemic. I think we can all agree that that is a recognized phenomenon. So now in the time of COVID, what role, like where to go with this now in the time of COVID? I think there has been a lot happening to educate pain prescribers of medications for appropriate prescribing practices, but that more needs to be done to just embed that into education so it's routine as people move into and out of medical school, let's say. I'd be interested in how you all see how this intersects now in the time of COVID. Yeah.
I would say I haven't necessarily honestly thought too much about that right now, but when I think about pain management and how we've gotten to where we are now in terms of the opiate crisis, I don't just think of pain management in terms of pharmaceuticals. I think about pain management in terms of emotional pain management, physical pain management, and spiritual pain management. So I think really what I'm talking about is trauma and how we look at that. So I would hope with this collective trauma experience that we're all having, that there is, you know, a different lens on how we treat all of those types of pain. And I think the physical pain has a lot to do with the spiritual and the emotional body. So to me, it's all connected. And I'm hoping that through this process, we're going to see a lot more alternatives be more accessible to people who are dealing with pain management. So that's my hope for what we're going through right now.
I like that response. That was a good one.
Yeah, I think hope for better future alternatives is like it's a really nice space to end on. I want to thank all of our panelists for speaking tonight. And I also just want to mention for folks who are attending that there's another event funded by the same grant that the Watertown Free Public Library is hosting on Sunday, September 13th. It's a panel entitled Ending the Stigma of Substance Use Disorder, Recovery is Possible. I'll put the link in the chat if folks are interested. And again, I just want to thank you all so much for being here. Thanks to our panelists, thanks to you all in attendance. And have a good evening.
Yeah, thank you for the opportunity and for everyone for joining.
Thank you, everyone.
Thank you. Have a good night.
Bye.